Okay, very good. We are here in the last afternoon of the EuroPCR meeting in Paris. Very happy to have you here, Dr. Alessandro Candreva from University Medical Center in Zurich. We have a long-standing relationship with Barbara Staley, head of the interventional cardiology team. And of course, you are also contributing quite significantly to the phase 3 study. We just checked that you are at least 99 and maybe already 100 patients in the study, so that is a major milestone. So hopefully, in the meantime, this last couple of days, maybe the number 100 may have been enrolled. That's a possibility, but certainly, yeah, you're working towards a 100 patient goal, I suppose.
Yeah, thank you, Hans, for the invitation and the opportunity to talk here at the EuroPCR. Yes, we are. Yeah, our idea is to reach at least 100, and well, ideally to kick Arus off from the podium. So they are third, we are fourth. We will go at least for the medal, let's say. Now, well, we had a very nice experience with the FEVR team and the group also. I have to thank the PIs of the team. They were always very, always reachable, and the study design was easy to be performed. So in Zurich, we have a very good experience. Also the technical support with the software license, everything was amazing. We do not experience any major issues concerning the recruitment of patients. So all the patients were actually quite thrilled to be included in a study where you have a modern solution to solve a problem. Actually, what we noticed that patients are quite prone to accept the not wire-based solution. Which of course, everybody knows that there has can be some patient also can cause potential issues. So yeah, I think we learned a lot from the study, and we are looking forward to the results of it. And let's see.
We do.
Finger crossed. Yeah, thank you.
But you and the team are involved in all kinds of studies, including QFR. But also, as we just discussed briefly, your experience in your daily clinical practice.
Yeah.
I mean, this is all study work that we are doing, but in the end, it is all about the daily clinical practice also. And once everything has been, the study has been completed, and hopefully that we get a non-inferiority with respect to FFR. But in the end, we do all of this for the patient.
Yeah, sure.
So that it can be used in daily practice. Can you say something about your ideas there, or maybe?
Yeah, sure. Yeah, Hans, you are raising a good point. I mean, as a university center, we have to deal with both phase of the issues. I mean, doing research, but also taking care of our patient. Of course, patient is priorities. We had some nice application of the technology, also not in non-standard patient. Like, for instance, we gave a priority to the non-wire-based solution, QFR in particular, for patient with contraindication to heparin, or patient you are not really willing to give some extra heparin shot. So, for instance, I don't know, patient with some recent stroke or intracranial bleeding. So one can say why they were there. Yes, well, sometimes they are there for many issues, because maybe they are 1 week or away from the stroke, so they can undergo the procedure. But nevertheless, you do not want to give extra heparin to do an FFR or something like this. I think this is a population of interest we have, we see quite common in the daily practice. And we had also some nice cases where, like, unfortunate young patient died, and before explantation for intracranial bleeding, for assessment of the organ donor, we might think about computing QFR, multi-vessel QFR in this patient population, which can be, I think, of interest also for the patient receiving the vessel. Concerning research, yes, we have established a core lab in our facility. We perform, of course, also assessment on invasive pressure tracing, but now we are specializing on not invasive ones. So QFR is also one of our focus of interest. What we are doing now, we are especially majorly interested in the multi-vessel analysis, especially in ACS patients. So it's a population where you might identify or maybe not a culprit lesion, like a non-STEMI population. It's not always the case. So QFR can help to identify the culprit versus the non-culprit, or when the culprit is clear, then you can then at the same time, without requiring the other vessel or without touching the other vessel, analyze the non-culprit vessel. And then maybe discuss about the stage procedure, what to do in the other vessel, without that the patient maybe has to come back another time to have an FFR measurement, which at the end is maybe negative or something. Yeah. So I think we have, from the research perspective, a huge amount of opportunities, and also from the clinical one.
The question is always, who does the QFR analysis per setting?
Well,
is that the research nurse? Is it a fellow? Not the interventional cardiologist, because he or she is active with the patient, of course.
Well, in our center, we have we are 3 certified operators. So we are, we do things correctly, and I think the best scenario is that we talk each other and say, okay, this patient will probably perform a QFR, so you maybe drop by and help me with that. This is, I think, the easiest way to go, but otherwise there is also the possibility to have the operator go out and perform the analysis. I think it's not a major drawback of the technology. I think it's something doable. Actually, we do like this also for when we want to analyze OCT and IBUS. So, of course, you can do from the joystick on the console, but in some cases, and I must say, we in Switzerland, we are very precise. We prefer to go outside and do things properly, take a few minutes. The fellow maybe stay on the table, or the nurse stay on the table. We go outside and we do the analysis on the image. And the same we do with the QFR. And we have with our we have the possibility to beam directly the image, so we do not have to close the DICOM, the case, and then ship the whole images. No, we can decide which image we want to beam, and then have maybe some high resolution imaging to help a little bit the procedure. Well, it depends, but I think it's the favor trial helped us also to establish this proceeding among us. So yeah,
that sounds like a very pragmatic and practical approach.
Yeah.
We really are very much impressed with all the work that you and the team is doing there. We look forward also to the results of those studies and the publications and presentations. So I would like to thank you very much.
You're welcome.
And give our best regards to the team.
Yeah, sure.
And we look forward to the results of the studies that we're taking forward.
Thank you very much, Hans. And
thank you so much.
Thank you very much. It was a pleasure.
Thank you.